she tweaked her knee the other day, so she's got her leg up and an ice pack on her knee.
Oh, I'm sorry. I'm sorry.
Me too. It's
All
embarrassing.
right, we are live. We should be live now. I don't know why it isn't showing.
It says on my screen, webinar is now streaming live on Facebook.
Hello, Facebook world. This is the Endometriosis Summit's Monday night Facebook Live. And tonight we have two extremely special guests joining us just out of the OR from Pacific Endometriosis and Pelvic Surgery. We have Dr. Cindy Mosbrucker and Dr. Tristan Neuville. Hello.
Hi,
and by the way, also up there in the corner is my partner in crime for the Endometriosis Summit, Dr. Andrea Vidali. We didn't want to leave him out. We were having a love fest with having Dr. Mosbrucker and Dr. Neuville here. Why don't you two go ahead and introduce yourselves?
So I'm Cindy Mosbrucker. We live in Gig Harbor, Washington, which is where the practice is. I grew up here in Washington, and I left when I was 18 to go to college and med school in Chicago. I got the Navy to pay for medical school, and so I went all over the world. After that, I was in Guam, and I was in Florida, and I was in Hawaii. And then I felt this little bird sitting on my shoulder tapping me saying, you know, there's something more you need to be doing. And I wound up going to work with David Redwine for 2 years, and he taught me endometriosis surgery. And after 2 years, I moved back home up to Washington State, and I've been here since 2008 doing mostly robotic surgery for endometriosis. About 75–80% of my practice is endo, and the other 20% is urogynecology. So Dr. Neuville is my new partner. She is learning. Well, you can tell them about yourself. I don't need to speak for you.
I met Dr. Mosbrucker when I was in the Army and doing some of my residency training here up in Washington. And then when I got out of the Army, I finished my residency in Georgia, and she had offered for me to come back and train with her so she can replicate herself. And I love her passion, and I'm also very passionate about endometriosis, and so here I am.
Human cloning is what we're all about.
Right, so it's very interesting that you both have military background. How does that, do you think that plays not only into how you work your team together, but into your approach to endometriosis?
I don't know. I think that a lot of people who trained in the military are real, just kind of pragmatic, problem-solving kind of people that aren't afraid to hit things head on and just deal with it. And as you know, it takes a lot of intestinal fortitude to get through some of these really bad stage 4 cases. And I think that, you know, just like fighter pilots, you have to trust your abilities, and you have to understand that, you know, what you can and what you can't do. And but at some point you just have to, you know, kind of suck it up and dig deep and say, I have to do this because there's nobody else to do it. And you know, not that you're unsafe, but that I think it has more to do with the mindset of the people who go into the military in the first place. That's my guess. You have a idea?
That sounds good.
Yeah. So I'm going to take this opportunity with Dr. Neuville. What is it like, because some of our viewers may not understand this, and we are going to discuss it at the Endometriosis Summit. What is it like to be a young doctor and to have patients come to you with endometriosis and then learn about what to do with them? Because it's very different what you're taught in med school and residency, and then how the path that you've taken to try to get some decent skills. Can you tell us a little bit about that, and how what it's like for you to try to develop skills in the current political environment of endometriosis?
Well, it is in most days somewhat frustrating just because I feel as though the education is not what it should be. Also with treatment, I feel as though a lot was left out and it was incomplete and unfortunately driven by most bigger bodied organizations. And not
Right. So what were you
necessarily-
taught? What were you, what were you taught that you should do for endometriosis?
Pharmaceutical medications and then ablation. We were not taught excision unless you were specifically talking about endometriomas. But yeah.
And then how did you have that mindset switch? You know, that you had to do something better. I know, she's
Sure.
amazing. What are we supposed to do with that? But because Dr. Eugenio Colon said he was tired of, he's also a younger doctor, and he said he was tired of seeing failure.
Mhm.
That the women would stay sick. So he went and did a whole fellowship just to do better. So, you know, what was sort of your revelation on how you had to do better?
Just meeting her and seeing this different exposure that actually worked and knowing that there's not enough surgeons that are doing it. And so, you know, wanting to be a part of that.
Cool. Cool.
She was starting her third year of residency when wasn't towards the beginning of your third year when she came and worked with me. And I could tell at that point in time that she had the best hands of any resident of any year that I'd ever worked with. And so I was impressed with her surgical skills, even though they were raw. She had just a ton of potential. And I was also impressed with her desire to do better than the status quo. You know, every day she was asking me questions about why is this so different than what I've learned in med school and in the first 2 years of residency. And I think it just, you know, that early exposure kind of started those wheels turning in her head. And not only does she have the, you know, the intellectual curiosity, but she also has the passion for wanting to make women better. That she wasn't going to just accept the status quo, and she wasn't going to accept what, you know, what was out there. And then, you know, the other good thing is she loves a challenge. She loves tough surgery, and she's not afraid of it. And so it's just, you know, she's the perfect package. She's got it all. She's got surgical skills, she's got people skills, and she's got the desire to, you know, to push through the hard days and, you know, and to learn everything that she's got to learn. So
and
Right.
she has a great mentor, because
Right.
I think it's something that we haven't mentioned, is the idea that without proper mentorship is very difficult to develop in an area like surgery, which is really skill based. And and this may be one of the problems that we haven't discussed, like, you know, the absent, you know, because there are fellowships, but do we really have mentors? You know, there are fellowships which are kind of loose. They put together, you know, okay, let's get a urogynecologist. Okay, let's get this, let's get that. Okay, now we have a fellowship. But really, the idea of mentorship and skill development. Do you want to expand a little bit on this concept, Dr. Mosbrucker?
well, I think AAGL has kind of missed the boat when they decided that they wanted their fellowships to be in academic centers. Back when they started them 10, 15, 20 years ago, whenever it was, they were more mentorships, and the goal was to put the fellows in community hospitals with docs who did their own surgery, and they operated like crazy. And so I do on average 25 cases a month. I did 25 or 26 in December, and I left on the 22nd for vacation for the rest of the month. So, I mean, I do probably 300 cases easily a year. And so it's high volume, it's high acuity, it's endometriosis and urogyn, and it's fistulas and the kind of cases that nobody else wants to do. And so I think having the continuity of one person is good. I think having the volume is good. You know, there's something to say for learning skills from several different doctors, but I think that the continuity and the volume probably overtakes that a little bit as far as importance. But you're right. I mean, it's something that everybody coming out of residency needs, whether they do a fellowship or not. You know, I see these kids coming out of residency, and it's really kind of sad because they're not ready to be on their own. They really need to be in a practice where they have people that are several years, if not, 10 or 20 years older than them, who can really help them along and help them learn, things that they don't teach you in residency, how to chart, how to, take enough time with your patients, how to make sure that you are caring for them emotionally and, not really spiritually, but kind of in that realm, as well as physically. And I think that there's a lot that's left on the table that isn't taught to these kids that we as a society of practicing surgeons could do better.
Great. So I don't want to veer off topic too much, but for anyone that doesn't understand what we're talking about, the status quo in endometriosis, we will fully read the standard of care set by the American College of Obstetrics and Gynecology at the Endometriosis Summit on March 1st. And so if you want to learn more about that, we have just about 17 tickets left. So we're expecting a sellout of the oversell this week. Let's get back to pain, because that's what we're supposed to be talking about tonight. We'll kick off the discussion with Dr. Mosbrucker. I'm just curious, what do we think causes pain when it comes to endometriosis?
Well, so pain and disease run in parallel. They are not one and the same. And so any given person can have, is going to have a certain amount of pain from a given stimulus. If you have 2 people or 3 people or 10 people, they're all going to feel that stimulus different. And it's their feeling and their perception that is pain. So for example, the sensory nerves that bring the impulses from the periphery to the spinal cord are called nociceptors, which means that they bring a noxious stimulus. Some people call them pain fibers, but technically they're not supposed to be called that because the stimulus is not pain until it is processed in the brain. And so these sensory neurons basically bring the signal from the pelvic floor, from the uterus, from the uterosacral ligaments, wherever, to the spinal cord. It travels up the spinal cord to the thalamus, which is just above the spinal cord in the most primitive area of the brain. And the thalamus is basically a relay center. And the relay center reaches out to the sensory cortexes, to the visual cortexes, and says, hey, are we seeing anything dangerous? Is everything okay? To the auditory cortex, are we hearing anything dangerous? To the memory center, and it gets input from all of these different areas of the brain to see if our situation is safe or if it's unsafe. If the other areas of the brain are telling the thalamus, yeah, everything's fine, it's cool, then the thalamus basically acts like a mom in the station wagon, turns around and tells these kids, you cut that out or I'm going to turn this car around and we're not going to Disneyland. So the spinal cord then shuts down these pain impulses from getting to the brain. On the flip side of that, if things are not okay in the other parts of the brain, then the thalamus, what it does is it ramps up those signals so that the person pays attention to it and does something. And the best lecture I ever heard on this was in Chicago by a guy named Lorimer Mosley. And he is a pain physiologist, PhD neuroscientist from Australia. And he told the story of a guy, primitive Aboriginal man, walking around out in the desert in thousands of years ago. And the stimulus that was okay was the sticker bush pricked his foot, and the stimulus that was not okay was a rattlesnake. And so when things are dangerous, then your body is programmed. It's like when you got your finger on the hot stove, your body is programmed to make a big deal out of it so that you do something about it. That's good when it's an acute situation and it's, you got to do your fight or flight reflexes. But it's not good when you have chronic pain and you have anxiety, or you have a childhood trauma, or you have other things that set up this idea of things are not okay inside your brain. Because then what happens is that those pain signals get ramped up and become bigger and more important than they ought to be. And it becomes more difficult to shut that down.
Well, it's very interesting. Oh, sorry, go ahead.
That's how anxiety increases pain. Now, that's not to say that endo and other things going on in the pelvis don't actually really cause pain, because they really do. But it just makes them that much worse in people who have problems with anxiety.
Right. It was very interesting last week. Dr. Susan Clinton, who will do our Change the Narrative lecture in the workshop, talked about how that primitive area of the brain is also next to the emotional center of the brain.
System. Exactly.
And so the connection between the two is very strong. And then when you throw in stimulus that is actually very painful, it creates a soup in which I'm sure people get told they're crazy a lot, but they're not. Now, Dr. Vidali, you do a lot of unexplained miscarriage cases. What do you have to say about endometriosis that doesn't happen to cause any pain?
Well, I think that this is a good question, because obviously it's the biggest enigma of endometriosis. I think, the fact that the symptomatology is not necessarily directly correlated to the extent of disease. And I see, as I deal with pregnancy losses and autoimmune causes of endometriosis, I see a number of patients who do not experience, or certainly don't present as a primary complaint, pain. But their reality, the truth is that once further investigation is made and questions are asked, one discovers that there are issues at play. Let's not forget, and maybe Dr. Mosbrucker will expand a little bit, in a few seconds after I'm done, that endometriosis is a powerful inflammatory disease, and the inflammation symptoms are not purely local. There are systemic manifestations of this inflammation. So I would say that although a patient may not experience direct pelvic pain as a primary symptom, or it may not affect her to the level that it affects their everyday life, I think that with in-depth questioning, one will discover systemic manifestations, one of which is actually recurrent pregnancy loss, believe it or not. But I think the link inflammation and systemic manifestations and pain, I think that's really where we have to expand more and explore more, because I don't think we're testing enough. I don't think we know enough on how the immune system interplays in all of this. And I think I'll be talking about that at the Endometriosis Summit, actually.
That's actually the Braverman Memorial Lecture. So Dr. Neuville, can you explain to us what the definition of central sensitization is? So many patients are told that they have that with endometriosis.
Well, it's kind of similar to what Dr. Mosbrucker was talking about as far as the some people perceiving pain as being much worse than someone else. And so when the brain has sent that signal to shut down, it ramps up other areas to be more aware of stimuli that they are receiving, whether that's the bowel or the bladder, or even the muscle fascial layers. And so then those organ systems, those areas will send stimuli to the brain as well, and become somewhat hypersensitized to stimuli as well. It's kind of, there's
Is there any, I see it online a little bit. Do patients who have persistent disease, sometimes they're brushed off as that it's just centrally sensitized pain? How can you tell the difference? And B, is there any kind of danger to promoting central sensitization as the cause of pain in people with endometriosis?
Well, I think that, I mean, in my 15 years almost of treating primarily endometriosis, I can count on the fingers of my hands the number of patients who had persistent severe pain that was from, in the absence of endometriosis, in the absence of adhesions, in the absence of pelvic floor spasm, that they just had persistent pain, which that I would call central sensitization. I would call that actually more like a pelvic version of what we used to call RSD, reflex sympathetic dystrophy, and now it's
Complex regional pain syndrome.
Yeah, CRPS, complex regional pain syndrome. And for those of you who don't know, aren't familiar with those, it's basically the same idea as phantom limb pain. So somebody has a traumatic amputation, their arm is gone, but they still feel pain in their arm. And so I think there are a very small subset of patients who have that going on in the pelvis. I would say the vast majority of my patients, though, that have persistent pain after excision either have one little spot that was missed, or they have adhesions, or they have, most of them, it's pelvic floor spasm and it's their bladders that are irritating them. Because the bladder is basically the biggest heat sink in the pelvis for excess neurological activity that's going on in the pelvis. Basically what happens is that the sensory neurons from the endometriosis come to the spinal cord, and the spinal cord sets up a backstop that says, no, we're not sending this to the brain. You go somewhere else and figure out what to do with yourself. And the majority of those kind of signals go to the bladder. Some of them will go to the vulva, because I think that that's the mechanism for vulvodynia, or we used to call it vulvar vestibulitis, where there's just chronic inflammation around the opening of the vagina and no good cause for it. And
it's
so
actually very, very interesting blog on our website right now that Dr. Shrikandi, who is a pelvic physiatrist working in pelvic pain, talks about almost a reflex of inflammation around the pudendal nerve from people who have had long-standing endometriosis, and that seems to be generating the vulvar pain. It's a very interesting blog for those that are looking to learn a little bit more about that. I try to explain to our viewers, vulvar pain is typically at the opening of the vagina, whereas endometriosis pain is further back. But go ahead. I wanted to segue into what are some other causes of pain anyway.
Yeah. So, but once we take care of the pelvic floor dysfunction with physical therapy, which also helps the bladder pain, then if we're looking at recurrent pain after excision, I would say the number one reason is adhesions. The number 2 reason is persistent endometriosis, either an endometrioma, which I always tell my patients with endometriomas that I think that that is the number 1 site of true recurrence, because if you've got an endometrioma that's, you know, the size of a tennis ball, you may have 1 or 2 that's the size of the head of a pin. And we're not going to slice and dice the ovary because we're trying to preserve fertility, you know, to see if there's a little teeny tiny endometrioma. Once in a while, we happen to run into them and we'll go ahead and take them out. But if they're that small, we're not going to see them when we take out the larger endometriomas, and then that may grow over the next year or 2 and become problematic. But yeah, I would say that, you know, central sensitization and a CRPS-like syndrome is probably the last thing on my list of what causes recurrent pain after excision.
Right. We have just a couple of questions. Well, first of all, let's ask Dr. Vidali, what do you think causes pain post-excision with endometriosis? And then we're going to answer some of the questions from the crowd.
Well, just from taking on, expanding on what Dr. Mosbrucker just mentioned, I would like to say a little bit more about the bladder, because the bladder is always a major challenge, I think. And, you know, you described it as the sort of like the pit of, you know, like something that attracts all this attention, this pain attention. I think the issue is more like, I feel that the bladder is a little bit like the brain of the pelvis, because the bladder has significant sensory input and also has a motor component to it, because, you know, the bladder has to sense bladder full, bladder empty, relax, initiate voiding. There's all these activities that have to happen. So it's a very active organ. And that's, I think, one of the reasons that causes a lot of sort of residual pain being present on the bladder. And additionally, I have to say that it's a little bit of unexplored territory, but I feel that more recently with more advanced testing, especially DNA-based testing, the possibility of a concurrent biofilm at the level of the bladder after excision, as if there is persistent bladder pain, should be investigated, because you need to rule out, even in the presence of negative urine culture, traditional urine cultures, you could find in selected patients the presence of occult biofilm type infections that should be treated and may abate at least some of the inflammatory symptoms that are present.
Okay, so we have 3 questions. I'll let any one of you answer on what is sciatic endometriosis, and how often do you see it as a driver of pain? How do you deal with it surgically? And then when you're done answering, I'm a physical therapist and I'll answer.
So true endometriosis of the sciatic nerve is incredibly rare. I think there's been like 10 or 12 case reports of it. There may be more now. That was probably 10 years ago when I looked it up. But it is very, very rare. I've seen one case of it personally. It is challenging surgery because the sciatic nerve is very deep in territory where even endometriosis specialists don't operate in very often. And so fortunately, it's not very common. There is one thing, though, that is incredibly common in women with endometriosis who do have pain in their sciatic, and that is spasm of the piriformis muscle, which crosses right over the sciatic nerve. The piriformis starts on the inside of the pelvis. It then crosses to the outside of the pelvis at the sciatic notch and inserts on the greater trochanter of the femur. So it's a hip rotator. It's one of the deep hip rotators, which along with the obturator internus muscle can easily get pissed off with endometriosis, which is why we frequently see a lot of women with hip pain and kind of a functional impingements who have endometriosis and pelvic floor spasm, because they also have pelvic torsion that will change the alignment of their hip joints. But it is super common to see women with endo have sciatic pain from the piriformis spasm.
So Dr. Vidali, how often have you seen sciatic endometriosis? We have a lot of questions.
Legitimate, pathologically documented sciatic endometriosis, I've seen it once. So
Yeah.
I agree with Dr. Mosbrucker. It's rare.
Yeah, as a pelvic floor therapist, I see tons of patients come in with sciatic symptoms. I believe that the first step is, you have to really take the deep infiltrative endometriosis off of the uterosacral ligaments. I don't do that. I send to a surgeon for that before I can begin to balance the pelvic floor with you. The other thing is, and we just talked about it, is tons of leg pain is driven by that bladder. So if you think about the nerve roots of the sciatic nerve and the bladder and everything, it's all its own soup. So first you have to clear out the disease itself, and then it very may well be that there's another driver, like as if Dr. Mosbrucker's a therapist herself. She just did that better than I ever could. But so we have a lot of questions about that. I do, if people are complaining about leg pain, I do hope that they've first seen an excisionist, but then also a physical therapist. We have another, go ahead.
Can I interject one thing? The thing that I have seen, the most common nerve that I've seen affected by endometriosis is the obturator nerve. And it's real common to see peritoneal pockets, which is where the peritoneal surface or the lining of our pelvis is kind of get tucked back underneath the ovaries, and it kind of sucks back, and the endometriosis is sitting right on top of the obturator nerve. And those patients will have pain in the medial thigh down to the knee and in the back of the knee. And that is something that when I have a patient who has pain in the obturator distribution, and I see a deep peritoneal pocket on the sidewall, and I'm digging endo off of the obturator nerve, I get really excited because I know she's going to feel better. And just about everybody that I've had with those symptoms has felt a lot better.
Right. So I actually had that happen to me, I want to say about 5 years ago, and there was fluid sitting on top of the nerve. So the minute they worked with that, I was left with another cause of pain, but the pain where I couldn't walk anymore definitely got a lot better, and I won a national tennis championship. But it is a huge cause of pain, and you have to see a surgeon that understands what a pocket is and how to work with it, and not to just leave it there. What about thoracic endometriosis as a cause of pain, Dr. Vidali? How often we have a couple questions about thoracic endometriosis. How often, we talked about that extensively when we had Dr. Rakuya here, but let's talk a little bit about how that may cause pain.
Well, I would say that, first of all, it's a lot more frequent. And the typical symptom is, at least how I see it, is a pain sort of comes across the chest, kind of like under the bra line. It's always described as that by the patients. And sometimes radiating to the back and up on the shoulders, sometimes on the neck. Frank intrathoracic endometriosis is rare. I've seen it, but it's rare. Whereas diaphragmatic endometriosis is frequent, and so it's a lot more common. And obviously, it's a radicular pain, it's nerve pain, and I think one of the biggest problems of diaphragmatic endometriosis is not recognized. It's just doctors don't look behind the liver. They don't go look. They don't look, or they don't put as much attention. It's just a cursory look. Or is everything looking clear? And then going down into the pelvis. It's just because the gynecologist's focus is always the pelvis.
Well, and the other thing is that you will miss probably 90% of diaphragmatic endo if you just look at the diaphragm from the umbilical port. You actually have to put a port in right below the rib cage, and then use a 30-degree lens so that you can look down and you can see the attachment of the diaphragm with the back. And so you can see the liver and the diaphragm meeting, and then you know that you've seen the entire diaphragm, because most of it will hide back there. I have the same experience as Dr. Vidali. I've seen one case of thoracic endo and probably, I don't know, 30, 40 diaphragmatic endo. But I've also seen hundreds of women who come in and think they have diaphragmatic endometriosis, and what they really have is myofascial pain, because as Sally can probably tell you better than I can, once the pelvic floor muscles are in spasm, they don't like being in pain by themselves. They want their friends to come and join the party with them. And so the first thing they do is they get the pelvic girdle muscles involved, and then they get the abdominal wall muscles involved. And when it's bad, you can even get the intracostals involved, which are the muscles in between the ribs themselves, which will cause pain and spasm, and it will masquerade as, you know, upper abdominal chest wall pain. And the patients think that they have endo on their diaphragm, when really what they have is myofascial pain that hasn't been adequately treated, probably because the pelvic endo, usually because their pelvic endo hasn't been resected and removed, so that their muscles will calm down.
Absolutely.
So we have a
You know,
very-
you saw me nodding, Dr. Mosbrucker, because I see, you just like, you're saying it as it is. In fact, I have seen patients, I've seen 2 cases of patients who've had actually cervical spine surgery when they had pelvic endometriosis with absence of diaphragmatic disease.
Yeah.
But like, you know, their neck was hurting, and somebody, of course, thought that was a great idea to do cervical spine surgery on them. So I love that you just said that. So true.
Yeah. We actually, for people watching that, and maybe Dr. Mosbrucker, Dr. Neuville, Dr. Vidali, who was not on with us last week, if you're interested in a very good description of how the diaphragm connects to the pelvic floor, Dusty Ann Miller was on last week, and she described each individual muscle and also a breathing activity that you can do at home to open your diaphragm and open your pelvic floor at the same time. She will repeat that activity during the Endometriosis Summit workshop when she leads our chair yoga and meditation. But sorry, the workshop is sold out. But she is going to do that again. You can scroll down our page and understand that connection a little more. Dr. Neuville, we have quite a few questions tonight about when do you send to pelvic physical therapy? And do you send before or after? So I'll let you doctors take a stab at it, and then the physical therapist will answer.
Well, if depending on their physical exam, it's not wrong to send patients to physical therapy first. If there isn't improvement, or if they haven't been seen by a surgical specialist, then that would be, you know, the next step for sure. Or if there's any time between evaluation and surgery dates, it's still a good option to pursue. But then definitely, if there's a lot of spasm on physical exam, it's very important to send those women to physical therapy after recovery from surgery.
Right. So as a physical therapist and also as a patient, I believe that we should be sending to physical therapy before to get them to do prehab. That's the fancy word. But we want to prepare your body for surgery, but also you want to evaluate what pelvic floor and what pain may be coming from the endometriosis, so that because excision is great for the disease, but it may not take care of all the pain. So if the bladder is generating pain, physical therapy can help with that beforehand. We can help with any of your little central nervous system stuff that's going on, any of your spasms. And also, I think there's quite a lot of preparedness, even physically, that goes into having surgery and having a mindset that's ready to heal that physical therapy can provide. And thank God I feel that way, because then I'm in the right profession. So, you have to take it all with a grain of salt. I'm going to ask Dr. Vidali and Dr. Mosbrucker, what about teens who have pain? What do we do? What should we do there? Because we know what ACOG wants us to do. But what should we do with a teen who has pain?
Well, in a way, I treat them the way I treat anybody else, which is if hormones are indicated, which, in a 14, 15, 16-year-old who starts having pain with their periods, I think it's perfectly logical to start them on birth control pills. But if 6 months later, they are still having pain, then I would talk about the option to do surgery and look for endometriosis. The challenge with teenagers is that the disease looks different. And so a regular OBGYN is probably not going to recognize endometriosis in a 16-year-old in the vast majority of cases, because it is much more subtle and much less hemorrhagic. You don't see the big red lesions and the big blue lesions and the big black lesions like you do in a 30-year-old, when the disease has sat there and festered for years and years and years. What you're much more likely to see is some little blistered areas, some little vesicles, we call them, maybe some white lesions that are just beginning to have fibrosis around them. Sometimes you just see a bunch of little brown bumps. And if you don't know, if you haven't operated on a lot of teenagers, you're not going to recognize what that looks like. And so I think for teenagers especially, it's even more important to get to a specialist who understands endometriosis and what it looks like in teenagers. But I mean, I absolutely think that, birth control pills, surgery, physical therapy, in that order, or birth control pills, PT, and then surgery is absolutely appropriate.
Yeah. Dr. Vidali, how do you evaluate a teen with pelvic pain?
Well, I would say that, first of all, I would like to expand a little bit on what Dr. Mosbrucker just said, which is that I think sometimes the young person, the teenager, is kind of in a double jeopardy, because the doctors, some of the doctors evaluating are very gingerly, because they're thinking, oh, it's a teenager, we have to be careful, we are worried about, the surgery. And then, so the surgeries, the necessary surgery sometimes gets delayed. And then at the moment of surgery, I think that with the goal of being quote unquote conservative, I see sometimes teachers have like these very minimal, like tiny ablations, excisions that are microscopic, and these are, like Dr. Mosbrucker just mentioned, these are patients in which it's very easy to miss lesions. So that you're even, if you just end up doing these tiny excisions, you're not really helping these patients. So I think they're really, it's really it's a challenge, I think for them to find somebody competent. But what I do is, my experience is that more often than not, teenagers show up with their parents. And what I usually do is I first have a conversation with one-to-one. I send the parents out because I want to hear directly from the person, from the individual, and so that they have a level of comfort to be able to say whatever they want to say, and only after that I actually, and when I've kind of gotten the whole story, I bring the parents in, because sometimes they may feel awkward, or sometimes the parents answer for the patient, which is like one of the most annoying things, but they can't help it, unfortunately. Maybe Dr. Mosbrucker, you want to expand on that?
No, I agree that, that's a good way to do the interview. The other thing that I wanted to say about teenagers that I think ACOG is really missing the boat is that I think that they need to be treated aggressively, by which 6 months on birth control, if they're not any better, and if the kid wants to have surgery, I mean, if the kid's like, no, I don't want to have surgery, it's not that bad, but the parent is pushing them, then I'll say, look, it's perfectly okay. You can wait. This is your decision. But on the other hand, if the kid is really miserable and wants to have surgery, then I think we should do it in a timely manner, because the longer that patient lives with the stimulus of endometriosis in the pelvis, stimulating their nervous system, stimulating their, the whole pain sensing system, the more likelihood there is of her developing central sensitization, and then having more, making it more difficult in the long run to get them completely pain-free. I think it's pretty easy, in the literature documents this, not so much for endometriosis, but for other things like, like neurological things like tic de la rue, which is the fifth cranial nerve that goes crazy, and people have this horrible pain from that the quicker that you can get it under control, the less likelihood there is of having persistent, prolonged, long-term pain. With endometriosis, there's a 9-year delay in diagnosis, and that hasn't changed in 20 years. And so the longer we delay diagnosis, the longer we delay treatment, the more chance there is of that patient having persistent, prolonged pain that is much harder to get in control, just because of the way that the brain processes pain and what chronic pain does to brains. So that being said, when I operate on a teenager, if they have a few spots of endometriosis, I'm going to do a wide excision, because Dr. Redwine proved in one of his studies, I don't remember which one, but that teenagers had the highest rate of recurrence of endometriosis, probably because they are still developing visually manifested endometriosis. And so if you believe that endometriosis is a genetic condition, that the seeds or the genes for the formation of female reproductive structures are turned on in girls with endometriosis from the day they're born, and then under the influence of estrogen, when they go through puberty, then the disease actually starts to grow, then it makes sense that somewhere between 12 or whenever puberty starts and 25 or 30, that disease is growing and it's becoming more and more visually obvious. And so in somebody who's 16, if say on one pelvic sidewall, they've got 3 spots of endometriosis, I'm going to take out that whole sidewall peritoneum, versus somebody who's 42 and they've got 3 spots. All we need to do is take out the obvious visible endo.
Right. So I had this whole conversation with Dr. Arrington of the Center for Endometriosis Care over the weekend, who was very active here on Facebook about teens and endometriosis, and the next question I'm going to ask you. But I often get parents who say, I'm a pelvic physical therapist and I still see patients, and they say, we just want to do the pelvic physical therapy. And I'll say, have you done an excision? And they'll say, well, our doctor, meaning their local gynecologist, so not a specialist, says that the pelvic PT will help with the pain and they can just take birth control for the disease. What is, as a pelvic PT, that drives me nuts, because that's not the role of pelvic PT. The role of pelvic PT is to help with the muscular and the fascial associations with pain. It's not to delay care. What do you think about how the average GYN might say, here, have this birth control and change your diet and go to pelvic PT? No need to diagnose, because of course we need surgery to diagnose, and no need for an excision. What's your opinion on that? Either any of the doctors.
Do you really want to know?
I do, because the Endometriosis Summit is an unfiltered environment.
It's hideous.
It's bad.
It's dare I say, malpractice for those girls.
Yeah. I mean, Dr. Vidali, what do you, and you must see it a lot. What do you think when that happens?
Well, as a general rule, I try not to, I don't like to alienate the general practitioner. I mean, I believe the general practitioner should be educated and informed, like I feel that it's really like the dilemma comes at the training level. It comes, how people are coming out of residency. I mean, that is the real scandal, I think. The scandalous thing is what's happening at the training level. People are out there who have been told and have been taught certain things are, in a way, they're victims themselves, in a way. I mean, I feel that the issue comes at a training level and what residency programs have to teach people. And really, how do we fix that? That is a very big question, I think, ultimately, because, as Dr. Mosbrucker just talked earlier, even the fellowships, this idea that academia, which should be like a center of knowledge and expansion of the knowledge system, instead, it seems to be, we're seeing a desire to preserve the status quo. This is the problem, the push is towards preserving the status quo. And it's very sad. It's like, I don't know, maybe you want to expand on it.
Right. So I'll point out on our Facebook, Heather Guidon of the Center of Endometriosis Care just put up a comment as if we all shouldn't see. People don't know that they don't know.
Yeah.
And so they do what they think might be in the best interest of that patient, but they don't know the information that should really be out there. That's why we're a patient and practitioner town meeting, because we want to teach everybody. We're not just there for the patient. But what impact do we all feel that Orilissa is having on blocking information and also on teens with endometriosis these days? Go ahead.
Well, I haven't really studied Orilissa because the data that I've seen on it is worse than Lupron. There was a Cochrane database review a few years back that showed with very high certainty that there was absolutely no benefit of GnRH agonists over progesterone and progestins. And so I don't use GnRH agonists or antagonists, either one. And I think I can count again on my fingers how many patients that I've seen in 14 years of doing this who actually had less pain and felt good on Lupron or Cinderella or Orilissa. I mean, even the ones that their pain is slightly less, they're like, I felt so miserable. My brain was gone. My bones hurt. I felt like I was in a fog. I felt like I was hungover all the time. They hated it. And then they couldn't sleep. They had night sweats. They had mood changes. They were irritable. They were, unrecognizable to their families. And very few of them actually saw much in the way of benefits. So I have to be honest with you. I haven't read all the data on Orilissa because it's nothing they can tell me is going to change my mind, especially after Dr. Redwine presented at AAGL that they had data that they basically manipulated in order to get the FDA to approve it. And so it's I just think it's a sad state of affairs. And I just want to say I shouldn't have said malpractice because that implies that the individual is doing something that is not standard of care. The real malpractice is that the standard of care is what it is.
Agreed. Yeah, definitely. It's a travesty. I would like to add that the issue is not, Orilissa or Lupron is not some sort of like an abstract concept. The problem, the drama is that in this country, in the United States, we are basically allowing the pharmaceutical industry to run the discourse on how conditions should be treated. And this is not limited just to endometriosis, for the record, but we happen to live in the endometriosis world, but it happens also somewhere else. You know, like in most countries in the world, pharmaceutical companies cannot even advertise for drugs. They can't. So what's happening here is that we have allowed a pharma company or pharma companies to drive the discourse and to make policy. That's all. I mean, of course, because they're all about that, they're going to push the policy towards, you know, prescribing more of these medications. This is the problem. The medication in itself, whatever, you know what I'm saying? I mean, you can't blame the drug. You know, the problem is that it's how the drug is sold. It's how we are allowing, our institutions are allowing this to happen. Our academic institutions, our professional organizations are allowing this to happen. This is the problem.
Right. Okay. So our hour is almost up. And I wanted to touch in with everybody. Dr. Mosbrucker will be joining us for the patient and practitioner town meeting. She will moderate along with Dr. Rakuya, the extra genital endometriosis panel. Has lots of surgeons on it, including Dr. DeLumba, Dr. Cernovo, Dr. Vidali. And I wanted to ask, like, you have not been to us in New Jersey yet. What are you most looking forward to?
Going to Frank Sinatra's hometown.
Well, Hoboken is a big draw, you know, because the kids are too. Yeah. Yes.
But, you know, one thing I would like to say, Dr. Mosbrucker, is that I think the value of being present, you know, in front of so many patients, and I think the energy and the validation of your work, you know, which you do get validation of your work, but I think that seeing so many people, actual people together, and knowing that each one of them will talk to 100 people, I think, and I can think that it is the patients ultimately who are driving, I think, this big movement, this big, you know, I don't want to call it a political movement, but it is a movement of patients who are demanding better care. So I think there's a great, I think you will find it exciting, Dr. Mosbrucker and Dr. Noville, sorry.
Yeah, no, I mean, I've spoken to our Seattle Endo group quite a few times, and the last couple of times, the room was full, and it was a big room. There were a couple of hundred women there, and their husbands and partners, and it is amazing, and it always amazes me when I go to AAGL and other meetings and talk to some of these patient advocates who really a lot of them, like Heather, have had their pain issues addressed. You know, they don't need to do any of this stuff, but yet they do it out of the goodness of their own hearts to kind of pay it forward in a way so that other women with endometriosis don't have to suffer in the way that they did. And I think that we've spent the last 20 years barking up the tree of ACOG and AAGL trying to get them to make changes, and they haven't, and they refused. And so, you know, having the patients themselves as the advocates is so far the most successful thing that I've seen in endometriosis. And you know, these gals have the power to change the world. And, you know, I say go for it. I'm more than supportive. I've had several patients who have, you know, been interested in what can they do to be more, you know, more involved in the advocacy. And I always try to help them hook up with the right people. And but it's the only way things are going to change. And so I think it's wonderful.
Yeah, so I like to point out that our keynote is Nancy Peterson. And that she exactly is the category that you just described. She was someone who had endometriosis, who was treated very, very poorly. and who has dedicated her entire career and her entire life to making sure life is different for every single person with the disease.
Mhm.
And she didn't have to, you know, so
No.
she did this because it was time for change. It is not easy for her to come to the Endometriosis Summit, and she wants to share that change with everybody else. And I think that is an inspiration for all of us that work in endometriosis, because she could have gone off and enjoyed retirement, but she didn't. And it is tough, the work that she does in endometriosis.
She's the Mother Teresa of endometriosis.
She is. So we are just about out of time. I will mention a few things. First of all, next week, I didn't check the schedule. Next week, we either have PT Palooza, and we have 3 physical therapists on, or, oh, hello, baby.
And he wants to say hi.
The author of Outsmarting. We either have the author of Beating Endometriosis on, or we have the author of Outsmarting Endometriosis on. I will keep you updated. In the weeks to come, we will also have Dr. Cernova. We will also have the producer of Endo What and Heather Guidone on. Tickets, there are 17 tickets left for the town meeting. The workshop is sold out. If you want one of those tickets, it's www.theendometriosissummit.com. And please join us in a round of applause for Dr. Neuville and Dr. Mosbrucker, who came straight out of the OR and right to our Facebook Live. We want to be so thankful to them, and to Dr. Vidali, who's going to go back and write 1 million charts tonight. So thank you to the docs for giving us your time. And we will see you right back here next week. Take care. Next week, we'll be at our regular 8 p.m. time. Take care. Thanks, Dr. Mosbrucker.
Thanks,
Thanks, Dr. Neuville.
Thank you.
Thanks, Dr. Vidali.